Mm. Okay. So, ma'am, I'll just share the screen and we can get started with this. So, good evening, everyone, and thank you for coming together and supporting on a Saturday evening. Thank you so much. So, so this is the second case discussion we have in lying after the 6th of July. This is the second series, the second in the series, and hope I wish to keep it recurrent with many more SLPs participating and talking about their own experiences. We have two terrific ladies with us today. We have Shilpa ma'am from Kolhapur and we have Poornima from Nashik, and they will be discussing two very different cases with us. So we'll start off with the introduction. So, a pathfinder and a passionate ASLP with strong personal and professional ethics, a continuous learner and a woman entrepreneur, heading 5 organization is Shilpa Huzurbazar, the founder director of Sanwad Speech and Hearing Research Foundation. She is the proprietor of all the 7 branches of Sanwad Speech and Hearing Clinic and Vijaya Foods. She is the treasurer of Astha Charitable Institute. She is the founder, director, and course coordinator at Rajiv College of Speech and Hearing. Among the many awards, ma'am has listed very few here. She has the Arogyam Dhan Sampad Award, the Rotary Award for Social Contribution, Innovation Award by Sakal Papers, Wonder Woman Award by MSME Honors, Tally, and many others. Among publications, she has a chapter contribution in a book on genetics and has participated in international research for autism. She's an ASLP with a cumulative experience of 34 years, a Manhattan trainer, and she is also trained for dramatics for special children. She's trained in peace assessment for swallowing disorder. She has training in assistive technology and has developed the first Marathi speech therapy software in 2001 and the CRM software for audiology clinic management. So now we'll start with the case. Ma'am, over to you.
Thank you, Debashmita. Thank you for this opportunity. And since this case is from non-Google era, I would like to tell it in a story form. I hope you enjoy the story. This is a case with stuttering associated with voice disorder. So one fine day, a mom came to me with two little twins, aged 2.5 years, very bubbly, and both were male children. Mother was narrating her journey, how she conceived them. She had to take treatment. So it was a precious pregnancy and had suffered lots of emotional trauma prior to this pregnancy. So it was planned cesarean birth. Larger amongst two was the case. She was more concerned about his speech. His motor and speech milestones were normal, very active as reported by mother, and also reported frequent shouting. And the case had reported to me 19 years back. So please perceive all the assessment styles for that era, because now over the years our field has matured so much. So she reported that child had started stuttering at the age of around 3, and that time only he had started going to nursery school. Mother was very anxious, could not manage 2 children. Their mother tongue was Marathi, and medium of education they had selected was English. And they were staying in a small town near Sangli. So it was a like rural area only, and they were known family from that region. Next slide, please. Can you change the slide? So the history and observations were, when I assessed, I interacted with the child. He had frequent URTI. A child was doing thoracic breathing, Repetition of initial syllables and blocks were observed. Word specificity with a and per was noticed. No secondaries. Rate of speech was fast. Even mother had a fast rate of speech. And mother anxiety was quite noticeable. During assessment, hyperactivity was noticed, voice was breathy, maximum phonation duration was 3 to 4 seconds, expressive language age was around 2.5 years, other sibling was more expressive and was dominating the conversation. So during assessment, I literally had to keep the other sibling away because he was answering whatever interaction we were having with the child. So next slide, please. So that time we used to practice being this may be a normal non-fluency. So we counseled them that this can be a normal non-fluency, and I advise them how to handle, not to make the child aware, and all the protocols we follow, encourage patient listening, and to reduce vocal abuse, like call him near, and you also don't shout at them. So use a softer voice and basic behavior modification techniques like praising them when they help, asking for help. So handling tantrums and follow up after 1 month. So mother reported after 1 month, but no improvement, and child was bedwetting. So regular therapy was advised, and we started with the therapy. So mother had shifted here. She had her parents staying in Kolhapur. So she said, I have 2 months holiday, so I'll prefer to stay and take the therapy. So they were coming regular. Next slide, please. So this was the therapy plan to improve MPD, improve breathing pattern, as it was thoracic and he was straining his neck muscles a lot, encourage vocal hygiene, improve attention span, parent counseling to handle tantrums as both were pampered at home, and mother was literally frustrated as grandparents were pampering them and she could not manage and control the children. This was the case at both places, at her mother house and even in her sasural. So both places she was suffering, and I had to do a lot of emotional support for mother also. Material used were toys, blowing therapy, and doll play just to vent out his emotions. Next slide. So after 10 days, not much improvement in voice and MPD. So we referred to ENT surgeon for assessment. So indirect laryngoscopy was done. As that time in Kolhapur, direct laryngoscopes were not available. Vocal nodule was suspected as child was hyperactive. He did not cooperate much with the ENT. Adenoids were present and medicines were prescribed by ENT surgeon. Next, please. Next slide. So during therapy, I had to prevent bringing the other sibling to therapy session because he was quite disturbing and was answering for the main case. After doing this, he got the full attention of mother, so attention span improved, his tantrums reduced, expressive language was worked on upon, and showed better experience sharing. Mother was asked to encourage turn taking while talking, so he gets a chance to report whatever is happening during play or in the school. But voice did not improve, and MPD raised only by 2, that is up to 5, but neck muscle strain was present. Bedwetting stopped as mother started paying personal attention. Not much improvement in URTI, and parents had a homeopath family member, so they shifted to homeopathy for upper respiratory infection. Excellent. So this was during 2 months, but later the school reopened, so started visiting twice a week. It was not so regular. Developmental misarticulations had improved by then, and tantrum decreased, but blocks at initial place continued. After repeated parental counseling, mother was ready to subject the child for direct endoscopy, a very new technology then. Next, please. So we stop here.
No, ma'am, you go summarize this, ma'am.
Okay. ENT plan. After consulting, she was not ready, and almost they took 7 to 8 months to accept that now child needs ENT intervention. So this was the ENT plan, as URTI was not reduced and child developed otitis media during this period. Adenodectomy will be done along with endoscopy. So we had kept the plan open. If focal nodule is large, with parents' consent, nodule will be removed. Parents were very reluctant for the procedure due to risk of anesthesia explained to them. They shifted to 2 different ENTs and were not trusting the first surgeon's plan, and took almost 3 months for the decision. So it was a quite long period. So I have been saying that by that time, child was 4.5 years.
And I'll just share the screen with you again, with everybody again.
So
Okay.
you want me to repeat the sentence? My
Will
learning?
do, ma'am. Please do. Please do.
It was I would like to hear from others. This kind of learning on the case is very important because it gives us a lifetime lesson. So this was a lifetime lesson for me, that rule out whether it is a vocal nodule, or nowadays we get good images and videos itself. So it is not the concern. But after that, I make it a point. If direct walk-in case is there, I send it to ENT. I have endoscope in my clinic and I ENT visit, so we do proper endoscopy and then proceed with the voice therapy. So cyst was removed and it was sent for checking, because that time the parents were counseled for child CA of focal cord may be present. So that was again a tension provoking counseling, which was creating anxiety in mother's mind. But fortunately, reports were normal, and adenopectomy was also done. And then his breathing improved, and so please change the slide. So now there comes a psychology point of view. Child had developed complex due to frequent, I think we are missing something. Frequent comparison with his sibling by his other family members. See how he's talking, why are you not talking? So despite repeated counseling that don't mention his stuttering, or please pay attention to good speech, because the percentage was not that much, but still he developed and behavioral problems kept rising. So mother used to visit irregularly for therapy, especially when symptoms used to increase. This was maybe during holidays when both kids were at home, and again the fights and all used to go ahead, and the child used to increase in symptoms. So MPD remained at 5.6, was still same despite all phonation exercise. I think the earlier slide was, this was the earlier slide. So parents decided to operate during surgery. I was present to support the mother. ENT found out that it is not a vocal nodule, but it's a cyst on the vocal cord. No laser surgery was available, and scope was also little advanced. So whole this procedure, I think, took 1.5 years from diagnosis to operation. So this was benign. and MPD became 12. Heart contacts were still present and we worked upon it. Okay, post-surgery, this was the plan to improve voice quality, to reduce heart contacts, and child was given the relaxation exercises to reduce his anxiety, and mother was also asked to practice during therapy sessions, so she remains calm. Because I think that anxiety transfer was from mother. And therapy was discontinued because child was talking fluently. Only once a while in 10 sentences, once he used to have heart contact. So frequency was very less. I don't recollect it because it is almost 18 years back. So after the child, after they stopped therapy, mother reported when the child was in second standard and he had poor scholastic performances, and we did IQ testing, SQ was normal, child was diagnosed LD. So he had letter reversals and typical symptoms, and therapy plan was given to him, and he managed to continue his studies, though he was not as good as his other sibling. But yeah, please shift the slide. So every summer vacation, they used to come and with new problems, and we used to solve, guide them. And the mother was working on him very well. So he managed. Now he is in, now what is, 2 days back only I called them since I wanted to present this case. Mother was really very happy. And he completed. Yes, the story doesn't end here. That is what is important. It's going to continue. Please next. Mother had continued in English medium instead of vernacular medium, as against the advice of speech therapist and psychologist. Child had developed severe inferiority complex, and to overcome that, he had become arrogant, disobedient, and sometimes aggressive. This was when he was in 8th to 10th. Now he passed out 12th, and
Ma'am, you went on mute.
the boy was referred to psychologist and then to psychiatrist, but they preferred to continue with homeopathic medicines rather than taking psychiatric drug. That was parents' decision. But now his aggression is less. He's doing well in his studies. He passed 12th science. And next slide, please. He is studying D pharmacy as they have pharmacy business at home. The other child is doing engineering and he has scored very high. So still there is a difference in performance.
Ma'am, you went on mute again. Ma'am, you went on mute again.
I spoke to her and the mother was so relieved. She said, I was thinking of you, maybe the telepathy, because I was thinking of this case. She said, since 10th, 12th, pressure was more and he has started stuttering again. He was better off till 10th. Now the symptoms have increased and I will come again for the counseling. So let's see what has happened now, any new development. So what were my learning from this case? ENT consultation in cases with stuttering is needed at earliest. Providing parental education and moral support in handling tough decisions. Impact of self-image starts in early childhood. And vocal nodule and cyst respond separately to voice therapy. These were my learnings. Thank you so much. And that's my team. If someone. Thank you. Thank you so much for patient listening.
Ma'am, this is a very small token of love from us for accepting it. I'll be sending it to you personally as well.
Thank you so much.
So
I think this
welcome
is my second case presentation in my life.
Ma'am, just as a discussion, I don't see anybody, nobody has really put a question in the chat. I hope if anybody has, even their own contribution, you can put it in the chat box for, I could read it out to ma'am. Ma'am, I would like to point out, that, like we were talking earlier, the kind of counseling you required, apart from the scientific part of it, like now you need the scopy done, now you need to go to the doctor. There was first you were handholding the mom, like new mom, precious pregnancy. She started out with a burnout. So, helping her to, manage the kids. Then comes the actual disorder, the actual problem, and the various facets. You want to go to a surgeon. Even if it were to happen to us, we would not listen to a single person. We would also want to, cross check it with people, validate with other people's opinions. And then comes the counseling for handling the kid, actually doing the therapy, your this thing. And you can actually see the generational trauma, like you're seeing now that, he has done DPharm, he's in family business and he is doing engineering. So a kid with stuttering has so much complex that he has aggression for which maybe medicines were required. So that is so much of gifted trauma. Like because of the
Environmental.
first slide was the pampering from the overriding grandparents overriding the parents and
Yes. I think it is environmental factor which we need to, even after this, we started inviting grandparents. This was my learning. I invite grandparents. Today itself, we had a meeting. So we purposefully we situate either online or in presence. Now we had some centers online and some who could travel to Kolhapur. So and we discuss their role, because now even more challenges are there with social media and mobile addictions. So we are taking their help. So it is very much important that we involve the entire family, even though stuttering and voice cases sound simpler as compared to autism or maybe lifetime risk. But
they are not simple. And they are not simple. They affect the self image so much.
yes.
Like, after 12 this has happened. Now if he were to shift his field or go for an interview somewhere, he's again going to come to you, ma'am, because of that stress, that tension. There are more number of issues which come up basically. So
One thing I have observed, they discuss all this in front of the children. What should we do? See, he's
correct,
not that sharp, so let him take care of our own business. So all the discussions are happening when the child is in and around. So
hmm,
that is also adding to
correct,
overhearing the conversations. So that
correct,
also we counsel. We see to it when we are discussing the case, the child is taken care by somebody, and then discuss with the parents about his weaknesses. You can discuss the strengths, but not weaknesses or any
absolutely.
major decision. So that I see to it that I do it separately. And I inform the child afterwards what I have spoken to that his mother.
Yes,
So he doesn't feel something is going on behind me about myself. So I tell him, okay, I have spoken this about you, and we want to plan. Maybe in a simpler and milder form, so he doesn't get that emotional trauma.
ma'am, but it creates so much of trust between you and the child you are directly working with because of that person, that confidential conversation that you have. That, I was just talking about this to your mom, basically. So, ma'am, we have a couple of this thing in the chat box. Maitri ma'am, thanking you for the presentation. Parent counseling is the foundation for any pediatric rehab. Sanika ma'am saying excellent presentation. Whether both adenoidectomy or cyst were done, or if yes, at what age, and if yes, then with or without age gap, ma'am. Question for
Uh,
you.
Actually, he was diagnosed, he came to me at around 3, and this was done at around 4.5 years because he had started ear infections. So, and that time, the tendency, now we say we wait for adenoids. So they'll subside. We have a better antibiotics and probiotics are there, but that time they used to do the adenoidectomy immediately. So at 4.5, he was operated for both because parents never wanted to subject him for second
Second,
anesthesia. So, during one time
correct.
operation, it was done.
Ma'am,
This
Savani
was the
ma'am.
right decision because stuttering, his emotional health was more important than waiting for adenoid to resolve.
Hmm,
So, and ear infections had set in. So again, he had developed otitis media, as I mentioned. So we were monitoring effect of adenoids on voice. It was there, in speech it was there, and it had started affecting hearing. So
correct. Ma'am, Savani ma'am says, very nice case discussion. Please shed some more light on the differences between a cyst and a nodule. Cyst doesn't resolve because it has an infective origin, and nodules do because they have an abusive origin. Is it that?
cyst is an infection. So
Correct.
maybe he had nodule earlier, and since he continued shouting and he had URTI, maybe ulceration had happened in that nodule and
Okay.
infection was there. So I tried, I had the photograph of that cyst. So I tried, but I could not found it. But,
Okay.
so,
Ma'am,
mm,
okay.
mm.
Shushri Smita writes, very nice discussion, ma'am. Is there any specific reason to shift the child to an English medium school?
They never wanted to. There, the comparison was important because they wanted to put other child in English medium. They said we don't want to differentiate,
Want to
and
separate?
they made him study in English medium. Though we had counseled him that don't put him. It's okay if both children study in vernacular medium. But parents were, grandparents, everybody were not ready. So he had to suffer this because they
Ma'am,
wanted.
because if his sibling was going, a vernacular school would look like a step down. Like, he's being
Yes,
given some
exactly.
sort of inferior treatment, basically.
Mm. So that's why they had put them in English medium.
Okay. Okay, ma'am. So I think that's it. So, ma'am, just as a summary for your longitudinal case, it was both stuttering and voice put together, and uh, it is because we are the ones who are working like closest with them with so many times, so we can thank everyone. Shushmita writes, thanks to you. It is necessary that our referrals matter, like at which point of time and what kind of referrals we are given. The follow-up counseling matter, because otherwise, despite the counseling, there is some doctor in the family, so and so neighbor got so and so something done. So for them to trust us, the repeated, however frustrated we may get that, in terms of the scientific direction, we are pushing them 1, 2, 3, 4, ऐसे karo, but things they might not be, ready to follow those. So the repeated counseling, I think, is where our emotional drain happens.
One more comment I would like. She mentioned that before coming to you, we have done thorough investigation about you. I inquired with many people and they all referred me to you, so I'm trusting you. So
Acha.
it mattered. And now, same case, now they go on Google and search your LinkedIn profile, but they say we keep inquiring and the patients, they don't trust like that. So
Yeah.
your goodwill with other patients also matter a lot.
Yes, ma'am. Ma'am, and in this case, like, I was describing earlier, the kind of counseling support here to extend to the mother, like from a new mother to a mom handling aggression through 8th, 10th, and now 12th. There were different kinds of support you were also giving. And um, as you have to really connect with the parent. So sometimes it doesn't happen. Two human beings, they don't get along. So in cases they get along and you manage the trust and the rapport, it really works, because then your reference work, ma'am. Like, going to what you're telling, you were there in the surgery to support the mom. That is something very big from.
Yes, maybe it clicked me that time. I said, okay, she needs it. And now I think over the period, your clients' moms become your friends also.
If
So
you're of the same
we
age,
develop a
especially, yeah.
family relation kind of a thing.
Yes, ma'am.
Your parents are and your clients are your family, extended family maybe,
Family, yes.
because they are related to
Okay.
you.
Thank you so much, ma'am. I think we'll wrap your case here, ma'am. Thank you so much. Please stay with us for Purnima's case as well.
I love to hear.
Okay, so I'll I'll Purnima, I'll just share my screen to get your presentation on. 1 second. Give me just 1 second. Um, Purnima, thank you for accepting this and being so willing to come and share a case. We can't hear you. 1 second. Are you on mute? What happened? Huh. Yeah. Yes. Yes. So thank you so much, Purnima, for accepting this and willing to come and share a case with us, the discussion, how you went with it.
After hearing Shilpa ma'am's case, I'm feeling that I'm blessed to present here. So at the end of my case, I'll be getting a lot of inputs from all the seniors who are already
Yes.
joined. I saw the list. There are many seniors. So I'll be saying that do listen and give me the inputs, because just now I understood that it's a long way. Being a therapist, you have to be with the kids for the long time. So I will say it's just a start for me. So all the listeners do give inputs after listening to the case. Thank you.
There are a lot of seniors in the audience today. You're correct. I
Yeah.
just saw the list. I'll just introduce you to everyone. Purnima finished her BSLP from EYGNISD and MSLP from BVDU, and she has a work experience after working at Krishna Prabhu Hospital for Geriatric Care. She's a visiting SLP at Dr. Desai's Occupational Therapy at Ratnagiri, a consultant SLP at Sri Guruji Rugnalaya Multi-Specialty Hospital at Nashik. She's the founder and head at Astitva Speech and Hearing Clinic. She is also currently working as visiting SLP in hospitals. She is a visiting SLP in Rusi Irani Special School, Deolali, which is a branch of Jai Vakil Foundation, Mumbai, and she is a member of Isha, Misha, and Rotary Club at Nashik. So now I'll go on mute. Hopefully, this is managed without much this thing. Over to you, Purnima.
Yeah, hello everybody. So I'll be presenting a case. The title of the case is Symptomatic Approach Towards Diagnosis and the Therapy in Case of Perisylvian Syndrome. So next. So this case reported to me in January 2023, that is around 16 to 18 months back. And they mainly came with the complaint that child is lagging in his expressive skills. So the child was just using abrupt vocalization and few rudimentary gestures and pointing. And as the child was, there was no any major medical history at that time reported by the parents. Next. So when the current that time the concern of the parent was that they were already attending therapies to some other centers, and as parents do discuss between them, so they were understanding that the child has to have good comprehension to start with the speaking abilities, and that was their first major concern, that our child can comprehend well, but why still he has not picked up in his verbal language. And even the ASD was ruled out, and ADHD profile was also ruled out. So they were very worried why the child is not able to pick up the verbal language, and he was comprehending so well comparatively to other kids. Even after the therapy, he was just using abrupt vocalization when they reported to me that time. So their major concern was related to the verbal language. And in pre-therapy that I saw was just a delayed milestone, motor milestone were there, and other things were evaluated, like BERA was done, and psychological evaluation for ruling out the ASD and ADHD profile was already done. So then I started with our general speech evaluation for the pre-therapy. Next. So as we all start with OPMA examination, I started with the same, and one of the observation for me was that the child has thin lip, then missing tooth, and his tongue was like a flaccid mass during the first evaluation, and the tongue has fasciculations too. And that was one of the concern from day one for me, because they reported that they were taking basic exercises, but it was like a literal flaccid mass of the tongue. So I thought that it is a red sign for the future therapy. So these two were first OPME observation, which were important from day one. Next. And as even the parents told me that the child language comprehension was good. So that was one of the sign that I thought it is better to at least have a apraxia component to be ruled out. So there was a significant difference in his language comprehension and expression. There were few oromotor tasks which he was able to do involuntary, and was not able to perform voluntarily, and he was not able to follow any of the command for oromotor tasks, and imitation skill for overall whole body was poor, and the child was already having occupational therapy. So I had discussed with the otist also about his feedback. So they also told me that the child has few praxis issue and balancing issues, and yeah, they also reported me that the child was poor at imitation. Next. So in the language evaluation, I could see that child was having a good language comprehension. And as I already told, their concern was correlating that expression was complete non-verbal. Gestures were majorly used, and his vocalization was very abrupt, and the voice quality was strained that time, and the medium of schooling was English and the ICSE board. That is also one of the important thing from pre-therapy. Next. So as I mentioned earlier, the voice was very strained. In first session only, I could feel that something is going wrong with his voice and tongue. So strained voice quality was also a red signal for me. And then I did a formal evaluation, which was also showing the same, that expressive language and receptive language had a significant difference. During the time of pre-therapy, the child was not having any neuropediatrician opinion. He was just under in one of the pediatrician, I guess, and OT was from 8 months, and he had done speech therapy at some other center for 4 or 5 months approximately. So I started with the therapy. Yeah. So I did first, then the diagnosis was speech and language developmental delay with apraxia and query dysarthria. That because I couldn't do detailed evaluation for dysarthria, so I didn't went for the detailed diagnosis whether it is flaccid or spastic. But I started with the symptom based therapy first for first 3 months. Yeah, then I made a first 3 months plan where the receptive language was no doubt it was better, but it was obviously delayed. So I just started with the receptive language with our or general traditional approach of extension techniques and everything. So the child was picking up on the language comprehension very well. But in expressive language, as the child was already using pointing and rudimentary gestures, so I thought to start with multimodality approach. And the child is very cooperative overall, and he's very good at picking up the things. So I started with first for 3 months AAC with low tech, like a communication board I started with. And yeah, it do help. And I added few vocalizations on AAC, also with some gestures also. So few gestures, vocalization, like imitation and gestures. I clubbed all these things for first 3 months, and overall I could see that child is able to imitate, though there was groping behavior, but he was trying to imitate. And low tech device like AAC, he was very well at using it. So in 3 months he started using the communication board very well. So like he actually used to point the outdoor activities also what he want to go for. So even for the therapies also he used to choose like which activity he want to do first and everything. So his AAC was one thing which helped me to start with his communication aspect, and it improved his overall, I'll say, his overall communicative skills, and the child started expressing him. Even the facial gestures with the AAC he started using. So I feel AAC was a kickstart for me to start with his expression skills. Next. But again, in OPME exercises, I started with the traditional approach, and I used few of the tools also. Like we have that speech care tools, which are good. So like tongue elevation toolkit and everything with the traditional approach. But still I couldn't see that. I was not at all satisfied with his tongue movement improvement. Nothing was getting improved, like the strength or even the fasciculation was reducing very minimally, and the mass was like, it is like it doesn't the mass was not trying to move only, it was like very severely affected. I was very cautious that why it is not giving me the results for the tongue specifically, because all other things were improving, considering the apraxia symptoms. His lip movement, jaw movement was improving, like he was trying to imitate all other non-speech and speech oromotor tasks, and he was also following few of the commands like blowing on imitation and all those things. But I was very cautious why he is not able to do any of the tongue movements. So again it was a red signal for me. And for apraxia I could see that the child was improving a lot. So I used few of the techniques like dynamic temporal and tactile cueing and few of the sensory inputs. There are many apraxia therapy online videos are available. So I took a base from that, and they are free. So you can watch their videos, and they tell you the steps also how to plan apraxia therapy. So even like you are working on imitation skills. So they have given you like you have to do first is direct imitation, and then you have to do delayed imitation, and then spontaneous imitation. So I followed apraxia approaches through online videos and everything, which was giving me good results. So I was satisfied with his apraxia signs improvement, but oromotor was again a concern for me. Next. Then, as I earlier said, the child had good language comprehension. So I even thought of starting with reading skills, because child was good at picking up whatever is visually given to the child. So I started with few sight reading words, and even I tried is child was I observed that the child is picking up Marathi better than English. So somehow I counseled the parents, and with the God's blessing, the parents are were following all the things. So they were ready to go for Marathi sight reading. So I started with Marathi sight reading, because for apraxia, when you are working on phoneme level, I personally use the Marathi phonemes like Barakhadi and everything. So I thought, why not to start with Marathi sight reading rather than going for English? And somehow the parents were okay with it. And then we started with Marathi sight reading. And even during doing the imitation, I was using the Marathi flashcards for the sounds. And then we made few flashcards for the Marathi sounds with pictures also. So it was a great help for me that, and I think it was a good decision to start with Marathi sight reading. And in 3 months child was started recognizing few of the phonemes like which are prominent. So prominent, or I'll say it is different. He started recognizing few of the phoneme on flashcards. Then after 3 months I thought that his tongue movement and voice quality is something going out of the track, and I could feel that the voicing is also little abrupt. So I counsel the parents to go for neuropediatrician opinion. Next slide. So after 3 months, I reviewed the case. You can see that language comprehension was improving, and then expression, I am saying it in terms of all the modalities. Like I could feel that the child is improving in pointing and using ASC, facial expression, gestures. Everything was improving like on track. But his tongue movement was a red sign, so I counseled them to go for a neuropediatrician, and they went in Mumbai for the consultation. Yeah, next. So I discussed the case with the pediatrician. Luckily, the pediatrician is also very cooperative. So he called me in the first consultation itself, and he was asking me, what do you feel, what is going wrong in the child's growth? So I told them that, sir, I personally feel that tongue movements are majorly affected, and few of the cognitive activities child was not good at. Like from the OT perspective also, the cognitive activities were showing us poor prognosis. And from the OT perspective, the child had hypotonia, and the strained voice quality was one of the thing I was worried about. So then the neuropediatrician went for the MRI, and in MRI we saw that it hyperintense signal was there in bilateral, frontoparietal, periventricular white matter region, and by that time psychological evaluation was already done, and then he said that we can't exactly correlate the clinical findings with the MRI reports. So he said what we can do is we'll go for basic medication. So he started with the basic medication for the child, and he said that we'll go for genetical evaluation after 3 months. And even the parents were concerned, like why we went for the diagnosis in depth was, I'll say, the parents' concern toward the diagnosis, because they could, as they were attending therapies every, like for OT, speech, their major concern was why the child is not giving us the expected result in the verbal language and what is wrong. Like they were always concerned for the diagnosis related to verbal language. So then we thought we'll go 3 more months for the therapy, and again I planned for the next 3 months. Yeah, next. So this is 6 months post first pre-therapy report and 3 months after the neuro consultation. So again, I could see that his child language comprehension was again improving well. He was on track, and his expressive language, as the apraxia component was reducing, I could see that child started using verbal language. So words and simple phrases like adding they with the words or nako with the words, like very simple, which doesn't had dental sounds. I'll specify that because child was not developing dental sounds. So like mama, like ai, ali, like that. So which were not having dental sounds, those phrases child started developing. And by the 6 months, I was able to go till phrases level imitation in terms of his apraxia symptoms. But I could see that the child was having poor speech intelligibility. I feel personally this poor speech intelligibility was a combined feature of apraxia and dysarthria. So child was good at phoneme level, and once you increase the number of words, his speech intelligibility was drastically reducing. And yeah, oromotor exercises were intensively done, and we were doing sensory inputs, and even the OTs were trying their hard to work on his oromotor task. So again, here you can see that even after 6 months, we could only get his protrusion. Only protrusion was there. There was no lateralization, no elevation. Like it was there, elevation was there, but it was very minimal. So because what child used to do is during elevation, he used to keep his mouth, like when he has to say l, he will keep his mouth in small, like he will open his mouth in a small like small way, so the l was able to say, but elevation was poor. So again, that was again a concern for me. And even his intraoral pressure was weak. So he had started blowing on command, but blowing was very minimal. The strength was very poor. Next. So I started few of the breathing exercises, and as soon as the child had started using meaningful phonemes and everything, I started with the voice exercises too, because as I earlier mentioned, the child had a strained voice quality. So I started working on his MPD, and then few of the relaxation exercises, laryngeal massage, few things I added. So articulation, in terms of articulation, I can say is majorly the dysarthric feature was there, like imprecise consonant, and the rate of speech is very slow that time. Although today also it is slow, but when he started speaking, it was very slow, and speech intelligibility was around 6 only during the initial phase. Again, I'll say, but working on all this aspect, I was equally giving weightage on his reading skill, because I wanted the child to express as much as he can through other modalities. So I shifted him to the words in reading. So by the time of 6 months, child had started recognizing few of the Marathi words, and whenever possible, he used to say also, like if the word has vowels, he used to say that while reading. So reading was a great help for me. And a child used to bring the cards during communication at home, like whenever he wanted few of the things, like his mother had made like pani and everything, so he used to bring the written cards for the communication. And written modality with verbal language expression was a good way of asking the child to imitate, because as we all know that apraxia needs lot of drilling, and in apraxia case we need the child to be very patient and supportive, because it is frustrating for the child also to keep on saying one thing for a long duration, and we can't change the exercises and activities also for the apraxia. So reading was one of the good thing. I feel child was okay for verbalization. And along with that, I had started using Jello also. It was also in Marathi. So child used to enjoy Jello, especially he is very good at expressing the emotions on Jello. So he was very good at that. So whenever he used to come for therapy, he used to say that I'm happy and everything. So very well in Jello also. And currently also he is using Jello, I'll say that. Next. So, but still, as I said, I was not like satisfied in terms of his tongue movement improvement. So I was stuck to that, why he is not improving in his tongue movement, and why his strength and the flaccidity is not reducing for the tongue. So I again, in the second follow-up with the pediatrician, I again discussed, and according to our first discussion, we went for the genetical evaluation. So even in genetical evaluation, first the neuropediatrician thought to rule out X fragile syndrome also. So they ruled out that. And then we did the genetical evaluation for Perisylvian syndrome, because whatever clinical findings I were having was a sign of Perisylvian syndrome. So they went for the genetical evaluation of Perisylvian syndrome. In that, even his parental samples were taken, and it was confirmed that the child had a Perisylvian syndrome, and his mother was a asymptomatic carrier for the same. Yeah, next. So after like the diagnosis of like the genetical diagnosis, we revised the overall profile, and then I revised even my diagnosis. Speech and language developmental delay with apraxia with mixed dysarthria, because he was overall also he was having few spastic symptom, few flaccid symptom. So we went for the mixed dysarthria in case of Perisylvian syndrome. And next. So after the diagnosis, we reviewed the case, me, pediatrician, and the occupational therapist. We discussed, because it is one of the rare syndrome. So we discussed how to go for the further therapies. And I'm fortunate enough that even doctors from Mumbai, they take a time and contact us who are working in Nashik, which is a good thing, I'll say. So we revised, and we planned for all the modalities and all types of rehab which we could provide in the city. So as I said, he was having strained voice. We could feel that his breathing was a chest breathing, and his breathing ability was affected. Even the otist was saying the same. So we in the team, we included the physiotherapist for a few months to work on his breathing, the thoracic breathing, and all the respiratory muscles, to increase his respiratory muscle strength, so which will help me indirectly for the voice and on even on dysarthria purpose. And then even we included sport trainer, means I want to mention that we started with the swimming in that, and whatever even he could, the trainer could do, like aqua therapy through some online videos he tried. Even that was a great help, because it was helping me indirectly. And in school, we that time he was in English medium. So we added a shadow teacher, and in June currently he is shifted to Marathi medium also. But during that time we didn't wanted the child to miss out, so we added shadow teacher also, and we explained the teacher and parents and others who were working with the child that the child as the child had good level of comprehension, he was understanding that he is not able to speak the way others are speaking. Like he had started verbal expression, but the child rate of speech is very slow. So he was shy in nature while talking with others, and he was like reluctant to speak in the open setup, like in schools, in activity classes. He is okay while talking with the those who are very known to him. So we planned a whole holistic approach that everybody is putting inputs for the child, and then we next, and then the therapy continued. So this is just a progress report after 16 months of therapy. So you can see his expressive language is almost age appropriate. Even sorry, language comprehension, receptive language age is almost age appropriate. Now the child is doing good in expressive language. I know there is a long way to go ahead because his dysarthric feature are actively there. Even the apraxia features has reduced to some extent. We are working on his rate of speech in terms of apraxic features. I'm still working on his speech intelligibility. In terms of oromotor functioning, tongue lateralization has been started currently, but still it is to some extent. So the range of motion is still affected. Elevation is also there, but it is slow in speed. So while speaking, when the child is using long phrases, that time I think the tongue elevation is not able to match with the speed. So that is one of the thing the child is having. That is one of the reason the child is having slow rate of speech, and other things are still there. I have a long way to go. His breathing has been improved. So based on his breathing, his voice quality is also improving, and his trained voice quality is reducing over a age. Yeah, next. And yeah, currently even his prosody is affected because of dysarthric feature. I'll say the prosody is affected. The child is still using monotonous speech, and he doesn't have stress and intonation pattern in his speech. His speech intelligibility is shifting from 6 to 3. It's not still 3, it is between 3 to 4. Sometimes it's 3 when the child is like I'll say more when the child is not physically fatigued. That time he could speak well, and it is around 4 when he is in that phase. And when the child is physically and mentally fatigued, his speech intelligibility is going down. But still we are working on that, and we have currently shifted his medium of schooling to Marathi, because I feel considering his expressive language and dysarthric feature, and the child's overall I'll say ki, like his emotional quotient, the child is very shy and emotional. So he might develop inferiority complex in English medium, because if he is not able to speak clearly, then he will understand because he has a good language comprehension. So we have currently shifted his medium of schooling, and which is giving us like it is just a month he has started Marathi schooling, but still the mother is saying that child has learned around 7 to 8 words which are not taught at home, and not even the therapy. He has learned it from the school. So I feel it is one of the good thing we could notice in after the change in schooling. Yeah. So and these are my coming next month's plans. So I'll be working more on his language, and then apraxia also, dysarthric features. I have to work a lot. Social interaction, as I said, the child is very shy and he is understanding about his speech features. We are working on his social interaction also. Yeah. Yeah. And I know you people must be thinking why I went for the genetical evaluation out of the track. So, as I said, the tongue movement was not really improving, and there was no medical diagnosis when the child came to me. So if there is any medical diagnosis, like any neurological condition or medical condition which is leading to tongue weakness, then according to that you can counsel the parents that okay, this is the medical reason which is affecting your child's tongue movement, or that is the reason your child has dysarthric feature. Like whenever I used to explain the parents that your child has all these features which will need a time to develop his expressive language, so they were consistent with the question that why he has such features, like why he has placid tongue, why his oromotor is affected. So that is the reason I was stick to the diagnosis, and the pediatrician was smart enough to pick up that only tongue movement is affected, which is a prominent symptom of Perisylvian syndrome. So the neuropediatrician directly went for the genetical evaluation rather than sticking to other things, because child age is also, if you consider the child age, when he came to me he is 4'9". So we don't wanted to waste the time in just trying out the things. So the pediatrician was ready to go directly for genetical evaluation. Yeah. So what is the take home message? Yeah, next. So I'll say you have to be doing the revaluations, you have to review the case, and whatever red signals you see, like if you are working in 2-tier or 3-tier city, try to counsel your parents to go for neuropediatrician, not just pediatrician, and like discussing the case with other professionals, like as my clinic doesn't have any other rehab unit, so I take initiative to call others and talk with them, discuss a case which is giving me a good I'll say results. And the parents has to be informed about the multidisciplinary approach also. Like sometime in 2-tier city, the parent says why we should go to a neuropediatrician. We can just go to a pediatrician and थोड़ा बहुत कुछ मिल गया, like specifically they will say मैम वो ओमेगा 3 ले लेते हैं ना फिर हो जाएगा. So you have to tell your parents that why they are also equally important, because over a time when the parents are doing the therapies, they just feel that only therapies, like do only OT, only speech, and one day the child will be like doing very well. So you have to be like you have to counsel your parents that everything is equally important. None of the team member is going down and going up. Everyone has an equal weightage to give a good result in your child. Yeah, and symptomatic therapy is there, but symptomatic diagnosis is also important. We do go for symptomatic therapy. It is majorly used in a private practice. But I'll say you have to consider it even if you want to go for a diagnosis. And definitely holistic approach is one of the effective way to give you the best results. Yeah. Thank you. Next. Sorry, I forgot. Yeah, I have recordings also. Though there is a long way, I just want to give a short review. So this is a pre-therapy. I won't say directly pre-therapy. It was around after 3 months when child had started meaningful imitation. Yeah. Ma'am, can you play the pre-therapy?
Yeah, 1 second, 1 second. I need to share computer audio. Just a second, 1 second.
Yeah.
Let's see. Tell me if you hear it, okay?
Yeah.
नीट स्पष्ट.
Yes.
अजून एकदा. ओके. आता बबाई म्हण. बाई. हा पुढे. आता म्हण ओम. ओम.
So here when the child had just started with the meaningful imitation, you can see that his voice is very strained, and even in Om it was a short duration, but the child was not able to sustain the MPD even for 1 second. So that was the start for the verbal expression, and this is just a few months back. This is first recording is that I'm is for that prosodic feature which I'm currently working on. So loudness variation I was working on during this time. So the audio is regarding the same. Yeah, and the second recording is his spontaneous speech. He is saying Shubham Karoti, but you can see its speech intelligibility is one of the feature which is still affected. Yeah.
करोति हाँ हाँ देवापाशी माझा नमस्कार
Yeah. So these are the current recordings, and we are still working on his majorly on dysarthric features, and the child is still continuing the therapy. I hope the child will be doing good in coming months. Yeah. Thank you. Thank you for listening patiently, and the case is open for the discussion.
So this is Poornima. This is a small token of love from Insightful. Thank you for coming and presenting. And there are already questions for you. So we are going to
Yeah.
quickly stop the share, and we are going to look at few of the questions.
Yes.
Okay, so first is Sanika ma'am asking you, please elaborate on the low-tech AC and the medication suggested by the pediatrician and for which symptoms.
Yeah. So low-tech AC majorly I used was communication boards and few of picture exchange modalities. I had made few customized communication board for the child, and it was just for few months because later on I shifted him to the Jello. So I tried to keep him on low-tech modality for the minimal time because the child had good language comprehension. And yeah, pediatrician, I'll just a minute. So pediatrician has given a lot of, like, he was changing the medication throughout the time. So like first few months there was some different kind of medication he was going through. Currently, I'll just tell which he's taking currently. So currently the child is only on two medication. One is Pediawise and Admenta. But he has reduced the Admenta dosages currently also. Initially there were many medications which were given, but currently these two only. Yeah, and NutriHealth. That three medications are currently going on for the child. So even the pediatrician are trying to taper down the medications currently. Yes.
What are the medications being tapered down?
Hello.
Yeah,
Can you just repeat?
Yeah. Which medications are being tapered down?
Tapered
What
down.
are the earlier medications, basically?
So taper down, they have 10 on 10 was there, Cognicare was there initially. Even that lactobrin sachet were given. Those things are tapered down now. That were started initially, but currently the child is not having all those things.
Okay. So
Yeah.
your next question is from Mitali Sharma. Interesting case. One question. How would genetic evaluation be of value? You've already answered a part of it, but
Yes.
secondly,
Yeah.
secondly, in her opinion, it's a clear-cut case of delayed
Yes.
maturation since his motor milestones were
Yes.
delayed. his praxis were either due to dysarthric components, so the diagnosis could be delayed speech language disorder with cerebral palsy.
Yes.
However, diagnosis does not matter as much as your intervention was
Yes.
effective.
Yeah, even initially I was also having that thought that the child is having something related to either cerebral palsy or something like a ischemic attacks or hypoxia.
Correct.
So I think when the patient came for the pre-therapy, they didn't had a CT and MRI reports. So first 3 months they were not ready to go also for the pediatrician. And then he was not improving in the dysarthric features. So I counsel, and when they went for the evaluation, the pediatrician ruled out the CP things. So first that was ruled out, and then he went for the genetical evaluation. So pediatrician that hyper intense whatever CT MRI result are there now, that give a false impression of CP, which was a discussion from a pediatrician. So because he said few of the things are correlating with the genetical like the syndromic case.
As well.
So yeah, so he said better to go for that. And the pediatrician was quite sure that this is not a case of CP. And I think we
Yes.
are not even the people who can, I personally feel we can't diagnose that the child has CP. That has to be done by the pediatrician, I guess. So
Yeah, it's a
pediatrician said that he has already ruled out that that is a profile of the CT MRI. Even we reviewed the
correct.
CT MRI after 6 months. So we had done it twice. Even the pediatrician had discussed the CT MRI report with his colleague.
Okay. I would also like to add to your answer to this
Yes.
question. Why was what value would be of genetic evaluation? More than definitely your intervention is going on in the way you have planned
Yes.
and things like that. But genetic evaluation or any neurological evaluation, mostly genetic evaluation, gives you a prognosis. So, Perisylvian syndrome is a subclass of something called as polymicrogyria. So here it is only the Perisylvian gyri which is being looked into, but there could be other small malformations on the cortex which has happened and which sometimes may not be very easily visible. So polymicrogyria is this is the way of describing, but once you get a genetic evaluation, you basically, microbiome is put on later. You understand if there is any tendency to develop, for example, epilepsy later. Okay, what are the muscular connections or the muscular comorbidities of the same disease, basically. So what happens when you get a genetic evaluation done? Definitely, it helps you with the next kid, planning the next kid, thinking about it. Where is the con of it is that you're thinking about only one disorder versus almost 10 lakh disorders which are there on the planet under the face of the sun. So basically, one second, I am not able to mute her. Just a second. So, basically, getting the neurological and then the genetic evaluation definitely helps in pinning down if there could be something else. Like you said, it was misleading into a CP scenario, which it was
Yes.
not. But very much like CP, the physio did work on the intercostal muscles. Otherwise, we would not have the support for the
Yes. So, I would add one thing is it is very important even for the parents, because someone has even added that question, why shifting the medium of language. So
correct.
that is important when you are counseling the parents, that it is a syndromic case, so you will have the limited prognosis or a longer duration for the prognosis. Like as I said, you can also see that in 16 months the child has only developed protrusion and partial lateralization, which is too slow. So when you are explaining the parents the reason behind the prognosis, then they can also accept why we are asking them to do the steps. So why even the
Absolutely.
parents are raising the question why we should change the schooling. So because child is doing good in reading, he has no other like ASD or ADHD features. So that their question is also very valid, that why we should shift.
Absolutely.
when you are shifting, you should also be able to explain the parents that okay, this is there, so you will have limited prognosis or a delayed improve, like you will need a lot of time to get a certain amount of improvement. So better to put the child in lesser pressure comparative to having a ICSE board.
Absolutely. So, Shilpa ma'am just wrote, yes, it is important to include a geneticist as your team member. So, Maitri ma'am writes, did she miss the audiometric results? I think you said that the
Yeah,
para
Bera
was
is done. Yeah,
done.
Bera is done. It was not.
Opium is affected, but apraxia is improving. Little confused.
Yes, yes, yes.
Comment on that.
Yeah. Even I had that when I was doing during the therapies. I used to also get confused whether it's apraxia or going to dysarthria. But there are few prominent features of apraxia. But I personally feel the apraxic feature were milder. So it is improving. But still, like few things are still there. So I know it is confusing.
Okay, so there are reports presently, it is just coming up that even, for example, in children with CP, where you are going to expect only dysarthria, right? CP hai, dysarthria hoga aur kya hoga, but there
Yes.
is masked apraxia. So because of some either cortical malformation or a neuronal circuit structure asymmetry, you can have a planning issue along with a muscular issue. So even though you train, you see the capacity, your strength is increasing, you are still going to see a lot of groping, which you kept on mentioning. That if the muscular strength is increasing, the physio is working, the OT is working, you're getting much better breath support. There is present data that in CP kids also, we push them too hard. Strength hai to kar lo. If you're having the strength, you should attempt a
But
word
still,
pointing. Still, there could be a programming issue, which is, seen as
yes.
apraxia.
Yes.
Okay, so Sushri Smita has a question. Is it all right to go for the sudden change in school? Doesn't it cause anxiety and stress due to unfamiliar environment, new routines, and the need to make new friends? The stress and
Yes.
adjustment period can affect the child's overall performance and motivation.
I'll add here that first thing is child is more from the traditional Marathi family background.
Huh.
So he is somehow he was having an anxiety. I personally feel he was more shy in ICC board school, English medium, because the other kids are
Mm.
talking in the another language which child was not able to cope up with. At
Okay.
least in this school, the child is, suppose if the child is saying ki ye, but his ye is I'll say intelligible. So the
Correct.
child sitting next to him, if he's saying nakko, at least the child is understanding he's saying nakko, like that. So I feel now the child is more confident in talking rather than in previous school.
Okay.
That is my observation, but definitely sometime for other few kids, whatever the Sister Meeta ma'am has mentioned, that can also happen. But
Yeah,
somehow in this,
absolutely. Absolutely.
I have not seen such things yet. And one thing I'll say, the school has changed just a month back. So I need to observe in upcoming time whether all these things are getting affected or anything I can observe. I'll be keeping this thing in my mind that I have to observe from this point of view too.
Okay, I would specifically like to, congratulate you on two things. That is literally not thinking about anything and starting with AC. That is awesome. Whether you're working with pictures, whether you're working with a screen, it is much better if you work with just picture, because then you develop pointing and it doesn't get in the way
Yes.
of intention that
Yes.
come to the human and not the screen. So that is like absolutely excellent. And the second thing, which similar school discussion happened with Shilpa ma'am also, the starting off with Barakhadi. So what happens is the Devanagari script is what you see is what you speak. So the fast mapping that is happening inside is exact in nature rather than another stage of A being A, those kind of things. So Devanagari script is helpful across any kid you see. If you start with Devanagari, it is so easy to get through to the kid. Forget the parents. It is so easy that even they can understand. Okay, the matras are the problem. Matras coming up with the matras is a problem, but definitely as a visual support, we are
Yes.
Indian, have so many native languages, and if they have a script, it must be used.
Yes,
So,
and currently I can also see the benefit of it because, as I said, the child is reading now. So when I'm working on the dysarthric and apraxic feature, like the recording for the Saregama, so
huh,
we did a chart of Saregama written, and the child was given the cues of raising the loudness.
hmm,
Initial, I didn't had that pre-therapy for Saregama, it was very monotonous. Though few
correct.
of the loudness variation was there in current video audio, but we have done it with the reading modality rather than just on doing on imitation. Because in apraxia cases, only auditory imitation do frustrate the child. That I personally
Absolutely.
see. So adding a written modality, and as it was Marathi, and as ma'am has already explained, it is very easy for us to work on such kids with the Marathi, like the Devanagari font.
Any Devanagari script, absolutely. So we need to use the phonetic nature of Indian Indian languages and articulation therapy. We get stuck up in the Western. So actually, this is much more helpful. And joining the dots sort of back for you, the prosodic thing that you're working with, even that could also be a part of the Perisylvian syndrome, the polymicrogyria I was talking about. It is not just listening; the perception of the intonation might be affected, because of which you are still working with it. You,
Yes.
you are you are at war with it, basically. Okay, so
Yes.
the perception, the ability to process it, and then the child being able to get those intonation and the prosodic features out are different things. So definitely the neurological and those genetic evaluation does give us a lot of input in how much is it worth fighting and how much is
Yeah.
genuinely
Yeah.
the limitation
When to
of the
stop
kid.
and when we can push on the child.
Exactly, exactly.
Yeah.
So that was really good. That was really refreshing. And both the cases we had today, there were so many components to it that you have to counsel, and you have to, again, for your child also, like Shilpa ma'am, the referral mattered, the parent listening to you mattered so much. Shilpa ma'am, you want to add something, or?
It was a very nice case. Even I got to learn. Thank you so much. And maybe uh, if time can be little late, I can join because this is a practicing time. And
Ma'am, then comes the Saturday evening time of family time.
no, Saturdays are hectic for us. Of course, I'll try and join with you. Thank you so much. It was a
Definitely, ma'am.
wonderful opportunity.
Thank you both. Thank you, ma'am. Thank you, Poornima, for making it so fruitful. You're getting very nice, this thing, insightful and engaging discussion, because there's so many components to look at and work at. And like Shilpa ma'am said, it was from non-Google era, and you are talking about genetic evaluation. So, like 2024, your perspective in your cases. So
Yeah, I
thank you.
would like to add that thank you so much. And if all, I know all the seniors are attending, so if anybody could add on the inputs, I'll really appreciate that. If you think something else can be done in such cases, or if someone has gone through such cases, do let me know if anything else I can do in such cases. And thank you, Debosmita ma'am, for giving a platform to discuss the case. Yeah, it is great to have so much seniors and everyone adding on the things. Thank you for giving the platform to present the case.
Thank you for making it so nice and worth our time. It was really wonderful. So thank you for the audience, for the community support we got. We are hopefully I'll see you soon. Okay. Chalo, we'll wrap up now. Have a nice Saturday after this. Have a nice Saturday evening. Chalo. Bye everyone. Bye. See you.